Thank you for the opportunity to talk about functional irreparable rotator cuff tears. My name is Eric Wagner. Miami University. This is my contact information. Please reach out to me. So I'm going to sort of talk a little bit about this idea of massive rotator cuff tears and the idea of a functionally irreparable tear. So you can see these all have irreparable. These all have tears. They're massive. They sort of retract back. E.A. Common introduced us to this first idea that certain patterns are not always amenable to repair, actually in 1934 in his textbook. So pretty crazy how long this concept has been around. And semantics are important. So massive does not always equal irreparable. Sometimes the definition of massive is greater than 2 tendons, greater than 5 centimeters, or even the subscap and infra being involved. It's also important to consider if you have this posterior superior tear, this does not equal this, meaning that on the left you can see pretty good functional muscle, on the right you see not so functional muscle. And these massive rotator cuff tears do have high failure rates, and that's kind of why we're talking about this, that over time, more and more studies have shown very high re-tear rates with these massive rotator cuff repairs. And this is an example of a long-term follow-up with a pretty high re-tear rate. And we're learning the idea of this irreparable tear from these studies with a very large number of repairs showing relatively high re-tear rates in these chronic massive rotator cuff tears. There's a lot of considerations to consider what it actually is irreparable. And these are some pathologic symptoms and other considerations that I sort of introduce you to. So I'm going to go through some of these just briefly. The chronicity is an important consideration. So you have a tear, as we know, they retract both from muscular shortening as well as tendon shortening over time. And the muscle belly then eventually turns from this to a much more irreparable version of this. And this kind of shows a really nice article from Carl Weiser, how the tendon sort of retracts over time. And you get this tendon retraction and interplay between retraction and fatty infiltration. Christian Gerber and J.P. Warren and others have shown us that the longer the symptoms, the worse re-tear rates, the worse overall clinical outcomes, and that these chronic tears don't do as well as the acute tears with higher re-tear rates and worse clinical outcomes. The other pathologic considerations are kind of all along a spectrum: retraction, tendon length, fatty infiltration. And it's partly because we know that when the tendon tears, the muscle shortens and you get this early stages of fatty infiltration. And then over time, the tendon actually shortens, and that's when you get the later stages of fatty infiltration. So this Didier Pate demonstrated to us that you have these different stages of tendon retraction, 1, 2, and 3, and that retraction has been correlated with failure, particularly failure post-op. And if you combine those that retract to or beyond the level of the glenoid, that the supraspinatus and infraspinatus fatty infiltration plus the retraction all are correlated with a high rate of irreparability. This kind of shows those that get retracted and the correlation of the irreparability. Tendon length is also important, as you can kind of see here. So as your tendon length shortens, as Carl Weiser and Christian Gerber taught us, you get this shorter tendon length, you get advanced fatty infiltration, and this is correlated with failure. So less than 15 millimeters, you get this correlation of higher rate of failure. And this kind of shows the 92% failure rate with either fatty infiltration at grade 2 or 3 and a tendon length less than 15 millimeters. And finally, Goutalier taught us about this classification of fatty infiltration, where you have various degrees of muscle compared to fat. Grade 1, you have mostly muscle. 2, more muscle than fat, but there's more fat there. 3, it's about equal. And 4, you can see there's more fat than muscle. And these are important considerations because as you get more and more fatty infiltration, your muscle becomes less functional. And we do know this happens over a period of 2.5, 3 years or so, where you progress to grade 2 and then eventually to grade 3 and 4. And this is associated with worse outcomes when you attempt rotator cuff repairs in these settings, as the further the worse grades of fatty infiltration, the worse outcomes of rotator cuff repair, and particularly when you combine it with the tendon length. And this kind of shows the fatty infiltration and how it's also correlated with the retraction and the reparable versus irreparable rotator cuff tears. So these are all some of the negative prognostic factors of chronic tears, degree of retraction, fatty degeneration, all these kind of considerations that you should sort of take into account. And these are at least what I think about: chronicity, retraction of the level glenoid greater than 15 millimeters or less than 15 millimeters of tendon length, and fat being greater than muscle. So some other considerations I'd implore you to think about. So revision setting in general, back in the 1980s, we knew that these were hard to repair when we were doing open rotator cuff repairs. And now we're doing arthroscopic. More recent studies have shown very high rates of re-tear with these revision repairs, particularly with regards to massive rotator cuff tears. So I think if you have a massive rotator cuff tear that re-tears, it's very hard to try to revise this. ER lag signs have been shown to be comparable to both imaging and arthroscopy. And if you have an ER lag sign, it's predictive of both fat infiltration and repairability. This study kind of shows furthermore, we do know that the acromial-humeral index is an important consideration as it sort of progresses. You have worse rates of that sort of progression. And this is shown with the Hamada classification in rotator cuff arthropathy, where as you get lower and lower into stage 3 and stage 4, and less HI, you're going to have an irreparable tear. So this kind of shows these considerations that I consider. And they're all kind of along a spectrum: chronicity, retraction, tendon length. They all kind of fit along a spectrum with revision, external rotation lags, etc. One thing you should note: more and more people like Steve Burkhardt and Pat Denard and Rob Hartzler have taught us that you can use ripsops and interval releases to get really nice rotator cuff repairs. And you can get repairs, but they still have the incomplete repairs are associated with fat infiltration and the positive tendon sign or retraction. And in my mind, intraoperative assessment is very difficult, as really it's more of a functional muscle and functional tendon. Is that actually be able to predict intraoperatively? I'm not sure if that's the case. So I actually make these decisions preoperatively instead of intraoperatively. That I think intact repairs, when you look at those fatty infiltration, that's really what, whether it's intact or torn, that's what sort of correlates with the degree of functional deficits. And remember, the sagittal view is really what's important to look at this. Well, so tendon tears are also hard to repair, and I consider most of these to be irreparable, and you want to consider salvage operation. And remember, the teres minor is important. So teres minor hypertrophy versus non-hypertrophy, it's a big difference, and can help to rebalance the shoulder if you have a teres minor hypertrophy. So Philippe Colon and Pat Denard, Joe Walsh taught us that the location actually matters a lot. And when you look at things like pain, in this example, any location can be sort of correlated. If you look at these different patterns of either anterior or posterior superior tears, those can lead to limitations in elevation. External rotation is really that posterior superior tear, so either supra and infra, upper subscap, or supra infra and teres minor, where you have the external rotation lag signs. Pseudoparalysis is also the kind of upper and posterior superior tears. And interesting enough, the supra and the subscap are the ones that actually didn't have very much motion loss, and really just were associated with pain. And it's because this loss of force couple is really what deals with the shoulder dysfunction that you see. So some final last thoughts I want to leave you with: my definition of irreparable. When you look at pathology, symptoms, and other, it's really tendon length and quality, fatty infiltration, lag signs, revision setting, acromial-humeral index. Those are the main ones I consider. You could talk about some other things like diabetes, chronic kidney disease, but that's going to be counterintuitive for even salvage procedures. So I kind of left those off. Remember the negative prognostic factors with regards to degree of retraction, fatty degeneration, and chronic tears, and that you not only retract, but your tendon also shortens, and that's an important consideration when trying to repair these. Always get a sagittal view, always be able to see the muscle belly, and analyze that muscle belly. And please reach out to me if you have any questions. Thank you very much for your time.